இப்பதான் வந்தேன் நான் கிளினிக்ல இருந்து.
Good evening to all. Welcome to Ask Your Mentor program, Season 3, organized by Tamil Nadu AOMSI. Today's topics are diagnostic investigations and nerve injuries and neuralgia. Mentors for these sessions are Dr. Senthilnathan for diagnostic investigations and Dr. Arun Kumar for nerve injuries and neuralgia. The moderator for the session is Dr. Pal Mathai. Dr. Pal Mathai is a director of Dr. Mathai's Dental, Implant and Maxillofacial Surgery Center, Mumbai. He had completed his graduation from Terna Dental College, Navi, Mumbai, and Masters from Noyer Dental College, Mumbai. He holds FIBCS OMS USA, MOMS RCSCD UK, Surgical Fellow AOMSI. He has published and presented multiple papers at both national and international level. We welcome you, Dr. Pal. May I now request Dr. Pal to introduce the mentors and start the program.
So, good evening to everybody who's joining us today. So, the first topic that we're going to be covering today is diagnostic investigations, and our speaker for today is none other than Dr. Senthilnathan sir. Sir is the head of Department of Maxillofacial Surgery at Savita Dental College. Sir's primary areas of interest are dental implants, oral oncology, orthognathic surgery, and trauma. And sir has been in the teaching scene for many years. He's trained so many PGs and he's got so many awards and academic achievements and publications to his name. So without further ado, sir, we'll start the presentation. So I will share the presentation, and then we are going to go through a series of questions that have been sent by all you, all the PGs, and we hope to solve all your doubts. So Jimson sir, shall I proceed?
Thank you, Dr. Paul, for the introduction.
Yeah, please, Paul.
Yeah. How do you differentiate a normal lymph node from an abnormal one on a CT scan, MRI, and PET scan? Senthil sir,
yeah.
So please.
Yes, Dr. Paul. Do you share the screen?
Yes, I've shared the screen. And the postgraduates can see the answers as well. But so please do explain and tell us what the main points are.
My dear students, I think this mentor session will be good for all of you. It's a good topic, also very interesting topic on investigations. Just it's an interesting question, how to differentiate a normal lymph node from an abnormal lymph node on CT, MRI, and PET scan. I think any related to the lymph node, usually we used to concern related with the metastatic node. Either this imaging will be helpful in the metastatic node to find out from the normal lymph node. So usually the PET scan and MRI and CT, whichever we used to recommend for the patient, whether any oral cancer or carcinoma is spread to the node, that node can be easily differentiated from the normal nodes in the other side or the same side. So the PET scan has the high, Dr. Paul, the previous slide also. The PET scan has the high specificity and sensitivity for the test. So it has almost 92% to 98% sensitive and specificity.
Hello, Senthil sir, I think we've lost you.
Is it connected?
Yeah, it's connected. It's come back.
Yeah. Yeah. PET scan has a high sensitive and specificity where you can say even less than 1 centimeter of node also can be easily identifiable. But CT and MRI, it's a 80 to 90% sensitivity. When lymph node size is more than 10 millimeter in diameter, it can be easily predicted by your CT and MRI. In CT also, conventional CT and contrast enhanced CT. CCT has the high resolution and can easily detect your lymph node, metastatic lymph node with the CCT. CCT and MRI has the highest amount of 80 to 90% of sensitivity to find out the lymph node in the neck. Lymph node, either the metastatic node or sometimes granulomatous node like tuberculosis and sarcoidosis also has to be evaluated with that. But PET scan has more kind of more specificity to find out kind of metastatic lymph node, which is less than a centimeter also, and it has the high sensitive and specific ratio. And what is the difference between the normal node and the metastatic node to see in a CT scan or MRI? Or next,
Yes, sir. I've gone to the next slide.
Yes.
So you can begin.
Node.
Paul, I think we have lost him.
Yeah, we've lost, sir.
Yeah, sorry. There's some connectivity issue.
Yeah, he's back. Yeah, yes, and please proceed. Yeah.
Hope. Sorry for some connectivity issue in my native. Sorry. I think coming to the normal and metastatic node to differentiate that based on the distribution. So normal nodes usually it's a chain of lymph nodes that it is scattered. But if it's a metastatic node, you can see that cluster of lymph nodes in particular region, level A, level 1A, 1B, or 2A, 2B. So it will be like a cluster. Coming to the size, the neck nodes usually less than 1 to 1.5 centimeter. If you see the shape of the node, usually non-metastatic normal node in an oblong size or elliptical size. But in a metastatic node, this node start enlarge in size and become a round node. Texture of Hello. Is it
yes, sir.
audible?
Yeah. Yes, you are audible, sir.
Is it audible, Paul?
Yes, sir. You're audible. You're audible. Sir, please continue. Texture.
Yes, I switched over to mobile. Sorry.
No problem, sir. No problem.
It's texture is homogeneous for the non-metastatic node. If it's a metastatic node, usually it's a heterogeneous in appearance. Margins are regular and irregular for the metastatic node. Capsules are intact in a normal, but whenever the metastatic node enlarge in size and some kind of extra capsular spread will be there. That can be easily identified with the either the CCT or the MRI. Even the PET will give a good view about the extranodal spread of the nodes. When looking at the border, it's a well-defined for the borders for the normal nodes. In a metastatic, it is ill-defined. Coming to the internal structures of the nodes, absence of hilum is seldomly seen in the normal, but most commonly it is present in the metastatic node. And if you see the metastatic node, most of the time it is necrosed. Centrally, it's fluid along with the necrotic mass. That is more common in metastatic node, but in a normal node, it won't be there. It will be like a oblong elliptical shape. And a calcification, coarse calcification in the normal nodes and microcalcification in the metastatic node. In a contrast enhanced CT, the uniformity of the enhancement is a homogeneous in a normal node, and metastatic node, it is a ring enhancement. To this picture, you can easily find out what is the CCT, the first image, where you can see the complete bone and normal structure of skin and adjacent subcutaneous and muscle. And here the node, actually, you can see the level 2A nodes. There are 3 nodes. One is adjacent, medial to the mandible, ramus of mandible. The other one just behind your sternocleidomastoid muscle, and it is round. The other one more node. That necrotic node, you can easily make out with the CT. It is like some kind of radiolucent mass within that node. High intense. Coming to the MRI, there is a baseline MRI T1 and baseline MRI T2. Here also you can make out there is a little bit of difference on both the images. The first image, you can see that there is a T1 and T2. There is, we will come to the MRI when we discuss about it. T1 weighted images, you can see a little bit of enhanced. T2 always, whenever there is a fluid, it will be more white in color. So in these 2 images, you can see that there is a second node, necrotic node. You can see a fluid within that node. So this also has a 3 node, which is in the level 2A. Next. Yeah, this is where you can see the PET scan. So PET scan, you can see the radionuclide isotopes is injected into the body. Then from that, based on the emission, positron emission, that images are captured and superimposed with the CT scan images. Here you can see the 3 lymph nodes that's in the 2A level. Each one contrast. That one is the first one is the fluoromesonidron PET scan. Then second one is the 18F fluorodeoxygluconate. These both are radioisotopes which can be injected, and 2 different images. These 2 you can make out. There is a FDG uptake is very particular and unique, limited with the lymph node itself. But the first one you can see there is a little more bigger in size of the images. That's not only the color, the image also. That makes that wherever there is a hypoxia, the nodes looks like around the node also looks like an image like. This is the both 2 different type of PET images. Coming to the third one, GTV and HSV, that shows that the two line marks are the one shows that cross total volume and hypoxia subvolume. These 2 differentiate the amount of the node which is involved in and around that, whether the extracapsular spread, which can be easily made out with the PET scan. So PET has a more specific and sensitivity for this neck node metastasis to find out. So always keep it in the mind. It is an examiner point of view also during the exam. What is the different imaging technology to identify neck nodes, and how do you differentiate between the CT, MRI and PET? So this, all the exam going student have to remember that what is the even contrast enhanced CT shows the nodes, and MRI how the nodes will differentiate than even in a PET scan. So always remember that PET has the high sensitive and specific for your to find out metastatic node in the neck.
Thank you very much, sir. That was a very, very beautiful explanation. So with this, we'll go on to the next question. Types and recent advances of CT scan.
Yeah, thank you for that. Types and recent advances of CT. So I think all of you know that conventional CT. What is the what are all the advances happened in CT scan? Just not only see the images, just to reduce the radiation exposure during the CT time. That is one of the major focus for the recent advances which is happening in the CT. So whenever there is a reduced exposure time and increase the imaging quality, and use of some kind of the speed of CT scanning, that is the number of slices increase in the CT images. And after all the two-dimensional CT images, just stitching the image and reconstruct the 3D images, either in a CT angiogram or in a 3D CT phase, the stitching all the images and make a reconstructed images. These are all the recent advances which is happening in the CT, computer tomography field. And there is something like artificial intelligence, which is also more very closely interact with the recent development, and some kind of the advances and inventions happening on mobile and portable CT scannings. Which is more portable CT scans is very, very important when the CT images are required. The patient who are present in the ICU, they cannot be mobilized from the ventilator. Those places and intra-operative field, this mobile or portable CT scans is very, very important. These are all the areas where a lot of research is going on and technologies are used to revolution in the CT scan is happening.
That's great, sir. Sir, what about the
coming to the
types?
Different types of CT scans? Yes, it's a non-contrast CT scan and contrast enhanced CT scan versus high resolution CT scan. Basically, as an exam going student, you should keep it in the mind. Most of the examiners shows that when you evaluate the CT scan, you should know what is the soft tissue window, what is the bony window. Then what is the contrast, non-contrast based and contrast enhanced.
Senthil, sir, your voice is
able to differentiate. Non-contrast, you can see a lot on the bony margin. Probably soft tissue might not get enhanced. But contrast enhanced CT scan, you can see the muscle attachment and tendon and ligaments, which can be enhanced and gives a good idea or clear picture about what we required in that particular area. So a carcinoma which is involving the bone as well as the soft tissue, which need a contrast enhanced CT, where you can completely see the bony expansion and involvement of the bone and erosion of the bone as well as the soft tissue involvement. What is the difference of high resolution CT scan and CECT? High resolution lung cancers. Whenever we deal the lung, where you want to see the lung parenchymas, like to differentiate the parenchyma with the lung cancer and to clear picture about the alveoli. This high resolution CT scan is very, very important to give a clear picture about the CT images, and it's a high resolution CT scan. So this all based on the contrast which we inject into the body. Then coming to the other types of CT scan, which is more revolution in the field, CT angiogram. I think CT angiogram, all of you know that it's very, very important when the patients are getting admitted in either MRI, MI or chest pain. Usually the people, either the invasive or non-invasive type of. Non-invasive is a CT angiogram, which we can start from the 16 slice to now 640 slice CT angio is available, where you can see the blood vessels or any occlusion in the blood vessels like atherosclerosis or any plaque or the perfusion of the blood vessels or any blockage in the blood vessel, this can be easily evaluated in the CT angiogram to find out any aneurysm or any stroke or anything. This also CT angiogram will be very helpful. Coming to the 16 slice or 32 slice or 64, 128 slice, these are all the slices where you can reduce your radiation exposures and giving a good image, and the resolution also will be more. So this usually implemented in the coronary angiogram, where you can the comparative between the 64 slice CT and 640 slice CT. 640 slice CT, the radiation exposure is very, very minimal, and in a one shot you can take more number of the images, and the square centimeter, that is 16 centimeters, can be covered with a 640 slice CT in a single shot, but 64 slice CT we can take it in a multiple area wise. So the exposure of radiation will be more. So based on that, so slices. And then what is the difference between the mobile CT and the stationary sheet? Mobile CT, it is more applicable and very useful when the mobile CT can be moved to the ICU, or when patient is inaccessible or very critical, which can be not able to shift to the CT, regular stationary CT scan. Or sometime in the operation theater also, this mobile CT is based on the whether it is a mobile or stationary. It's a mobile CT and the stationary. So open gantry versus closed gantry. I think nowadays most of the CT scan are the closed gantry type, because the exposure or the exposure of the complete gantry is not acceptable by the, sometimes they get the claustrophobia by seeing all these machines. So mostly or what we are using is a closed gantry. What is the difference between the conventional versus spiral CT scan? Conventional CT scan, where there is a radiation is exposed, the in spiral CT, the radiation is exposed all around the body. That is, patient also moves within the CT scan gantry. So the radiation exposure is reduced in the spiral CT scan. So the image quality also much better in the spiral CT compared to the conventional CT, and exposure of the radiation also very less in spiral CT.
Thank you very much, sir. So it was a very detailed explanation. I'm very sure that all the students will no longer have any problems. But sir, there's a good point that we should note, that whenever it is a CT scan, the blood vessels will appear enhanced and opaque compared to an NCCT scan. That's a simple point that our PGs can remember for at least differentiating between both.
Okay. Yes.
Okay, so moving on to
it's a good
next
point. Yes.
So moving on to the next question. What is digital subtraction angiography?
Okay. Yeah. It is also very interesting for a maxillofacial point of view. It is a fluoroscopic technique used extensively in interventional radiology for visualizing the blood vessels. So interventional radiology has a major role whenever we deal with any kind of the vascular lesion or vascular tumor or vascular mass within the jaw bones. We have to always closely associate it with them when we find out the feeder vessels for your AV malformation or the tumor which is present in the jaw, either the mandible or the maxilla. Digital subtraction angiography is subtracting the bones or eliminating the bone images from the this will be very helpful. DSA or digital subtraction angiography is very much helpful when there is a aneurysm, endovascular aneurysm repair, or whenever we do the balloon angiography, or when we place the stent in an occluded vessel, coronary vessels. Especially DSA is
very much useful when we assess the coronary angiography and when we plan for stenting in an emergency basis or in an elective basis. This DSA will be will give a clear picture. You can see that images without the DSA and DSA. The first image, you can see the bone which masks the angiography. You might not see the clear picture of how. The second image with the DSA, where you can see the clear-cut, well clear picture and high-resolution picture in the angiography, how the blood flows. These two images, you can see a big difference. So digital subtraction angiography will subtracting all the bones or radio opaque mass from the angiography. That is the mean is digital subtraction angiography image, which is much helpful in a lesion like, or when the condition like MI or where you have the coronary block. This will be very helpful in the maxillofacial region. In case if any carotid block or carotid occlusion where you want to subtract the mandible and see the complete coronary vessel, this DSA will be very helpful in the neck region.
Okay, sir. Thank you very much. I think this has really solved some of the doubts that the PGs have. So moving on to the next question: role of scintigraphy, SPECT, SPECT, and PET in condylar hyperplasia.
I think coming to the image, Laji, our PGs has to know about the nuclear medicine also, where radioisotopes, which is injected into the body, which is get absorbed very fast in the soft tissue, and it takes little time to absorb in the bones and the hard tissue. All this scintigraphy, SPECT and PET all comes under the nuclear medicine, where imageology has a lot of recent advances to enhance its diagnosis in this field. Role of scintigraphy. Scintigraphy is a two-dimensional platform where you can see the this radioisotopes, whichever is given IV, that is absorbed by the tissue, that emitting of this thing is captured by the gamma cameras. If it is given a two-dimensional, it is a scintigraphy. In plain scintigraphy and SPECT, the radio tracer which is used is a technetium-99 methylene diphosphonate, which is get observed and start emitting. It has a sensitivity of 70% for the scintigraphy for the condylar hyperplasia, but SPECT has a 90%. It's a two-dimensional as well as three-dimensional images can be get from this. SPECT is a single photon emission computed. Radioisotopes is injected into a body. The patient has to be properly screened. They have to check for any kind of allergy to these medicines. Or after injecting this radio. Sorry, is it okay?
Yeah, audio was just breaking. It's come back.
Okay. Once we inject the radioisotope, we have to be very clear on the patient's reactions. If anything, any allergic reaction happens to the body, or any kind of the reactions that has to be evaluated. Sometimes won't take 1 to 2 hours to get this radioisotope to completely observe and emits the rays. So then once it is emitted further, then in a plain scintigraphy, it is evaluated in a two-dimensional way. SPECT is for single photon emission computed radio tomography, where the emitted photons are captured and images are formed. In PET CT scan, emitted positron is recorded in a tomography. where the gamma cameras will observe these positrons and produces the images. In PET scan, the radioisotope which is used is 18F or FDG, fluorodeoxyfluconate, which is injected into the body and takes time for 30 minutes to 1 hour. After that, you have to take the images. If the bonus, if it's a condylar hyperplasia, takes time and emits its a positron. These images are captured by the gamma cameras, and these are basic images. Yeah, these are all the images, 3 images. It's a basic images for the abdomen, where you can see that CT image, the first one, SPECT image where photon emission which is captured, CT and SPECT, which is both are combined, that is called fusion of these 2 images, will give a good anatomy or the extension of the tumor or the lesion very clearly to orient with the adjacent structures. Yeah, this image actually shows the PET scan, fusion of PET scan along with the CT images, both and the PET CT versus SPECT CT. What is the difference? PET, you can see the very refined margins, where in a SPECT you can see the little bit of the scattered images also. Notes that it's more spatial resolution features. Coming to the condyle, so we want how this PET, SPECT and scintigraphy very helpful in the condylar hyperplasia. That is the question. When this nuclear or radioisotopes are taken by the body, it is get observed and it start emitting the that is captured by the gamma cameras. So this has, you have to compare with the normal condyle and the hyperplastic condyle. In a hyperplastic condyle, you can see the relative percentage uptake is more than 55%. An increased condylar uptake of more than 10% compared with the opposite side. Radio tracer count ratio is greater than 1.10. Condyle to clivus ratio greater than 1.44. Enlargement of condyle with sclerosis and ground glass haziness has to be clearly evaluated on either side. This image will give the what is the hyperactivity which is happening in the left side head of the condyle. This images also will give the where is the hyperplasia, what are all the levels of bonus which is involved. So this scintigraphy will give a good clear picture about the condylar hyperplasia on left side, where on the right side you can see the clear cut condylar shape, not much of the hyperplasia on the right side. Even in the 3D reconstructed image, where you can see because of the left side condylar hyperplasia, the entire face is shifted towards the right. So excessive in the bowing of the mandible, this you can make out. But only the absorption of the radioisotopes you can see in the middle picture, only in the middle axial CT scan image, where you can see the hyperactivity. This way, this scintigraphy will be very helpful to rule out normal condyle with the hyperplastic condyle. I hope it will be a little more informative for all of you.
Yes, sir. So it was very well explained. Jimson sir, I'm just getting some feedback saying that some of our voices are not audible from some of the postgraduates. If we need to look into it.
I think your voice is clear, but the pencil's voice.
Okay, got it, sir. Got it. Okay, sir. So moving on to the next question. What is the application of the C-arm and the O-arm?
Okay. Yes. Yeah. That is also a very interesting question as a exam point of view or the examiner point of view. Always, what are all the intra-operative imaging techniques which will helpful or very useful during reduction of the condyle or as in the maxillofacial field, doing the arthroscopy. What is the difference between the C-arm and O-arm? Basically, we will come to that. C-arm is usually the two-dimensional images. It's a very low resolution, but O-arm is a high resolution where you can get the 2D image as well as 3D images also. So C-arm will be helpful, especially very in orthopedic and spine surgeons, where they use for simple starts with K-wire fixation to all kind of nailing, and it will be very helpful during the intraoperative time, whether our fixation is right or properly reduced, and check the screw length, and all that C-arm will be very helpful. The same way, O-arm also will high resolution images, and you can get the 3D images also. When do the spine surgery, this O-arm will be very, very helpful. These two, C-arm and O-arm, what is the use in the maxillofacial region or the maxillofacial field? This is applicable in various area in the maxillofacial, especially when inaccessible area. Suppose if you do the endoscopic repair of condyle fracture, or fixation of condylar, endoscopic fixation of condylar fracture, or K-wire fixation in the condyle, or in arthroscopies, where to find out the proper position of the probes into the upper joint space or the lower joint space. This C-arm and O-arm will be very helpful, especially in neuralgic pain also. If you want to give neuralgic pain, to relieve, this C-arm as well as O-arm will be very helpful to find out the foramen ovale, or to find out it is in the skull base, foramen rotundum properly with this. This has a major role in maxillofacial field also. These two imaging, C-arm and O-arm.
Okay, sir. Thank you so much. Moving on to the next question. What is the imaging that is recommended for deep space infection?
Okay. I think in the neck, deep space infection of the neck, I think neck anatomy itself, it is a very different. I think all of you know that whoever do the neck dissections, mostly you know that lot of muscles, lot of fascia, and lot of vital structures, and prevertebral fascia, parapharyngeal spaces, and multiple potential spaces. So this imaging, whenever there is an infection in the neck, the imaging is very, very important. Starts from a superficial infection, can easily identify by the ultrasonogram or ultrasonography, where you can find out the fluid or the space infection can be easily found out. Then CECT, as I told you before, to evaluate the contrast enhanced CTs has a major role in the neck infection, either the deep infection or the superficial infection. Even sometimes to drain this infection also, CT guided aspiration can be done, or CT guided FNAC also can be done with that for any kind of the infection in the neck. Contrast enhanced CT has the major role for the MRI also has a role. MRI, you can see all this muscles and fascia and different spaces. But considering the infection, the contrast enhanced CT has the major role to find out and which spaces are involved, whether this is around the carotid space or peritracheal space or prevertebral space or paratracheal space or parapharyngeal space, especially from the neck, like Ludwig's angina, where you can see we might not know which spaces are involved, and where we have to do the sometimes deep neck infection, we need to aspirate and find out what kind of the organisms which causes that. So for this, the CECT will be very helpful, very, very helpful to find out the deep neck infections. As a student point of view, first you can give the options to the examiner that CECT is the standard of gold standard to find out any kind of the deep neck infections.
Yes, sir. Thank you very much. So with that, we move on to the next question. What is the difference between T1, T2, PD weighted and contrast MRI?
Oh, yes. Yeah. We come to the MRI. I think there's the same question we have seen in the first question also about talking about the T1, T2 MRI and flare MRI. I think before that, I want to explain the students. I hope all of you know that electromagnetic field. What do you mean by the CT scan? You can take out in 10-15 minutes time, but sometimes the MRI will take more than half an hour to 45 minutes time. What is happening in the MRI room? I think all of you have to know that MRI electromagnetic field is created around the body or wherever the lesion or wherever has to be diagnosed or examined. So around the electromagnetic field, the cells or the nucleus, there's all the protons are changed coming to the field. By the time radio frequency is applied to the tissue, wherever it has to be examined, the tissue gets reflection from that echo. The MRI images are created. That is based on T1, T2 and proton density based or flare based images. The first image, second image and third image, you can see that there's a lot of variation in this all MRI images only. What do you mean by the T1 weight, T2 weighted and flare? Even you can see for some structures how whenever there is a fluid that more bright in the T2 weighted, and T1 you can see the CSF fluid, it is a dark in T1 weighted image. T2 you can see the bright, and flare it looks like a little bit of the gray in appearance. The same way the white matter of the brain looks lighter in T1 weighted, dark gray in the T2 and dark gray in the flare. Same way the cortex gray in T1 weighted and light gray in the T2 and light gray in the flare. Fat, it is more bright in the T1. T2 it's a light, flare is the light. Whenever there is an infection, it is a dark in the T1 weighted. T2 weighted it's a bright and flare is bright. So what is that? Well, suppose whenever you want to see the different images and to find out, to rule out whether the fluid, even that when we assess the necrotic node in the neck, first question in 2A, when there is a necrotic node, the center of the node has a fluid. That T2 image, you can easily make out that around the node, within the node, that the fluid is very much white in color. It's a bright white in color. So that shows that, I think this image you can see, there are two of the second and third images, the baseline MRI T1 and T2, where you can see clearly you can make out the difference between these two images, how the muscles enhancement and the fluid enhancement and the tissue inflammation enhancement. Here you can see the clear-cut make out in the T1. It's not much of the, but T2 it's a more precise and enhanced appearance. So this difference is very much important when we assessing the tumor, or when we assessing the spread of the tumor, or in oncology when we assess the metastatic nodes and metastasis within the neck. So when we are reading the MRI, so as a postgraduate point of view, this T1 weighted, T2, the difference you have able to give the answer to the examiners.
Thank you very much, sir. So with that, we go to the last question, the role of ultrasonography in maxillofacial surgery.
Yeah. It is also a very interesting question for examiners to ask. Tell us the usage of ultrasonography in the maxillofacial field, or how will you use the ultrasonograph, or what instruction will you give for the sonologist to see our pathologist? It's a good question. So coming to the ultrasonogram, all of you know the basic principle behind it. Always send the sound and get the echo and record it and make it as an image. This ultrasound machine has the capturing the things also, detector, as well as to send the sound waves. It's more than 20,000 hits, so it's not audible by the human beings. This high density ultrasound is going and hitting the different tissue structures and making different echo. Based on the echo capture, the images are created. This is the basic principle behind all the ultrasound, either the echocardiogram or Doppler or simple ultrasound, which is used in the maxillofacial region. So usually once the ultrasound will be very helpful to see like parotid tumor or thyroid tumor or any salivary gland tumors, or to see the floor, any kind of the cyst, which is soft tissue cyst, which is present in the floor of the mouth or root of the tongue, or sometime like lymph nodes, to differentiate the lymph node and the salivary gland. Sometime whether level 1B, some of the node or the lump which is present in the submandibular region, we might not know whether the glandular enlargement or the lymph node enlargement. To differentiate easily, this ultrasound is the basic principle thing, whether it is a nodal enlargement or the glandular enlargement. Then other than that, suppose any kind of the sialadenitis or sometime any calculi or silolith present in the salivary duct, which enlarges the salivary gland or making the sialadenitis in the parotid or the submandibular, which can be easily evaluated by the ultrasound. And any kind of the vascular lesion like hemangioma or lymphangioma, which is present in the neck or the facial region, can be evaluated simple test with the ultrasound. Or any solid or cystic masses which is present in the maxillofacial region or the neck can be flowed. So ultrasound has a major role in the maxillofacial region. As a student point of view, you should know what are the areas which can be used to assess simple abscess, like whether it's only the submandibular space infection or it is spreading to the other spaces like sublingual or a parapharyngeal, which can be evaluated preliminary with the ultrasound. Or if it's spreading into the other, like becoming like a Ludwig's angina, which can be easy tool to identify the infection in the neck or the facial region. It's ultrasound is a very helpful. The same way to ultrasound guided biopsy, which can be easily done whenever the inaccessible area or nodal enlargement. The ultrasound guided biopsy will be very helpful, or ultrasound guided aspiration also can be possible if it's an abscess. So this is the way the ultrasound will be very much helpful. For the exam point of view, also examiner will expect all kind of these answers from the students. Hope all of you understand the usage of ultrasound in the maxillofacial region.
Thank you very much, sir. We are done with the questions for today, and we've really covered a lot of things and shared some very important pointers for the PGs for their exams. So, sir, once again, thank you. And with this, we are going to start with the second part of today's session. So, sir, I'll be stopping the screen share at this point.
Yes.
Thank you very much.
Thank you for all the students and Evomase for giving this opportunity. Thank you, Dr. Paul and Dr. Jimson.
Thank you, sir. Thank you very much.
Thank you.
Okay, so with this, we are going to be starting with the next session for the day. And let me just introduce our next speaker for today. That's Dr. Arun Kumar, sir. Dr. Arun Kumar, sir, is an associate professor in the Department of Maxillofacial Surgery at GDC Chennai. And sir has been a very active member in the academic front. He's also the vice president of the AOMSI Tamil Nadu and Pondicherry branch. He's also an IBOMS fellow. And we hope to learn a lot from sir today regarding a topic that is very commonly kept for the very last moment in all our exams, right? And we always pray that questions on neuralgia never come. So with this, we'll begin with the session. One second. So the first question for today, sir, is what is the Jinwala incision?
Yeah, thank you, Paul. Am I audible?
Yes, sir, you're audible.
Fine. Okay. First of all, I'd like to thank and proud to be part of the Tamil Nadu AMSI branch, particularly under Jim. We have been very active doing all these webinars, and we have a meticulous team as well. Ilavenil, Sasikala, and Kalpa, and also Paul, who has been very meticulous in organizing this mentor program.
Thank you, sir.
So let me start today. And also special thanks to Sendil, who has been very elaborate with all these investigatives. It has been a gray area for all, literally gray area, MRIs. So I also learned a lot from Sendil. Thanks, Sendil, also. Hope I'll do some justice in answering a few questions, which I know. Right. A Jinwala incision. Right. Jinwala is the father of oral maxillofacial surgery of India. This incision is basically, it's for trigeminal neuralgia. It's for peripheral neurectomy, particularly for the inferior alveolar neurectomy, which enters the mandible through the mandibular foramen, right? To reach the mandibular foramen, which is on the lingual side of the ramus, this is a Y-shaped incision, that is an inverted Y, which starts along the coronoid process, right? That is the anterior part of the ramus. Coronoid process extends down to the retromalar region, where it splits into two, right? One on the buccal aspect, another one on the lingual aspect, leaving a island of area in the retromolar trigone area, which is very difficult to elevate mucoperiosteally. Sometimes you may have an impacted tooth as well. So to avoid that area, this is given. And the lingual extension is given particularly to reach the inferior alveolar nerve, which is on the lingual aspect. So you just retract it cleanly, identify the lingula, then you can use a skin hook and something to retract, to hook the nerve. Then you can divide the nerve in that region. And one more incision is placed on the mental foramen region, so that it has to be cut. That nerve has to be severed over there also, so that it can be pulled along with the artery forces from the mental foramen region, or in the rather in the mandibular foramen region, so that it can be easily winded off. This is a procedure for peripheral neurectomy, Jinwala incision, right?
Thank you very much, sir. So with this, we are going to move on to the next question. Is trigeminal neuralgia a state of allodynia?
Yeah. Definition of allodynia is, there are a lot of definitions of pain: allodynia, hyperalgesia, algesia, all these things, right? So allodynia, basically trigeminal neuralgia is a state of allodynia. It's true, actually. According to the definition, any stimulus which is not supposed to create pain, right? If it creates pain, then it is called as allodynia. It is not an exaggerated, it is an exaggerated response for a lesser stimuli. Usually, if you have a pain threshold for some stimuli, even for like a feather touch, if you have pain, so it calls an allodynia, right? That is basically trigeminal neuralgia has trigger zones, which just feather touch or even a breeze might stimulate pain. So this is a typical case of allodynia. So trigeminal comes in a allodynia. And what is the definition of hyperalgesia? Hyperalgesia is you feel more amount of pain, right? There should be a painful stimuli which induces pain in normal individual, but the patient's reaction will be exaggerated. That is called as hyperalgesia, right? And there's a subtle difference between allodynia and hyperalgesia. Mostly it's commonly used for both ways, but the clear-cut definition will be allodynia, you get pain with a substandard stimuli, right? That which is a lesser stimuli like a feather touch or a breeze. So that is your trigeminal neuralgia is a clear-cut case of allodynia.
Thank you, sir.
Okay.
So moving on to the next question, what are the recent advances in diagnosis and treatment of neuralgias? So I think the first slide we've just put so that you know what traditional therapy is, right?
Yeah,
and
we are just brushed off these things.
yeah, exactly. Just so that you know, just because to know what's new, you need to know what's traditional first.
Yeah.
Right. And now, so we're going to move on to the newer therapies. So, sir, if you just tell us 2, 3, what do you feel are the important ones, we'll just stick with that.
Yeah. Always trigeminal neuralgia, you don't go to the latest therapy actually, because it's a chronic process and you always start with the basic thing, right? So that you can buy some time and the patient also have relief. It's not alone for buying time, but the patient also gets benefited, not straight away jumping into the final terminal procedures. So it should be a stage procedure. Usually we start off with the carbamazepine, which gradual increase in dose, 100 milligrams to 200 milligrams, up to 1200 milligrams per day, right? That is how we start the treatment. And few other drugs also can be used. Second line of like lamotrigine or famotidine or baclofen, and other epileptic drugs like pregabalin and gabapentin have been used along with carbamazepine or in isolation. This gives very good results. So you can have trigeminal neuralgia in control for a few years with these drugs. If it is not going to work, or if there is a side effect to these drugs, then we switch over to the next one. Next one we address is at the peripheral level, right? That is all your neurectomies, all those things can be done at the peripheral level. That is where they exist from the foramen, like your mandibular foramen or a mental foramen, if it is a mandibular nerve, or if it is an infraorbital foramen region, if it is a maxillary nerve. That is how you treat peripheral neurectomy. Either you can destroy the nerve by using a scalpel and then cut it off, or you can use some alcohol, boiling water, whatever procedures you can do for a peripheral level. And the next level, if it is still persistent, if it is recurrent again, then we go in for a ganglionic level, right? It's not at the root, it's at the ganglionic level at the Meckel stave, where these are all a bit away from our field. Actually, you need some other specialist along with us to do these type of surgeries. That is, you need an interventional radiologist as well to navigate to the Gazerian ganglion, where we can do a glycerol rhizolysis, rhizotomy. Rhizos means roots of the nerves, right? You get a rhizolysis, percutaneous glycerol, that is alcohol injections or radio frequency thermocoagulation. Basically, you destroy those roots so that you elevate from the pain. That is what you do at the ganglionic level. And the last one will be a microvascular decompression. I'll come to it a little bit later. So that is the last stage. That is the ultimate terminal stage of your therapy. The newer drugs which has been used has been Vixotrexin. This is a sodium channel blocker, and usually most of these drugs will be anti-epileptic drug, right? It suppresses the seizures or something like that. So that is how it is used. And esicarbamazepine is a third generation anti-epileptic drug. Sumatriptan, this is a 5-hydroxytryptamine receptors. This also has been used. Intranasal carbon dioxide sprays, right? That is also has been tried. And nerve combing. What is combing? This is called as an internal neurolysis. Basically, the nerve is split into fibers, right? You just, when you use a comb, right, you just everything is just split into different types. That is how we use this nerve combing. You split all the fibers, and the most fibers which causes the pain may be identified and then lyse. That is how we use the nerve combing. And some of the other drugs have been used as called as capsicum, lignocaine, misoprostol. All those things have been used. Calcium channel blockers have also been used in some therapies. Mostly it will be used as a common combination therapies, or trial and error mostly, whichever fits into the patient. It's not particular to all patients. So some patients may respond and some may not respond. So all these things can be tried before getting into the surgery. And most of the patients don't want a surgery immediately. So they can be managed for a few years with these drugs. And pulse radiofrequency has been used. It gives it's a thermal therapy, right? Because it destroys the nerves by using a pulse radiofrequency waves, right? Basically, you have to destroy the nerves by whatever form, either by a chemical cautery or like electrocautery or something like power radiofrequency, pulse radiofrequencies. And another therapy has been used as prolotherapy. That is what we use for commonly for TMJ arthroscopy, right? Prolotherapy. You just inject the area with the dextrose or some ringer active solutions, which can be used along with the medical therapy, right? And ozone have also been tried both for TM joint pain as well as for this trigeminal neuralgia, where inject into the Gazerian ganglion. All these things can be tried. Cryotherapy again, by using cold applications to destroy the nerves. Basically, all these things are for men to destroy the nerves and then create the pain, right?
Sir, we are going to talk about the advances in the imaging now for for neuralgias.
Yeah, imaging has been extensively covered by Sendil. Anyway, I'll just brush it again. Traditional MRI, again, it gives a high resolution sequences. Mostly, you can identify the vascular contact on the trigeminal root, right? That is the compression where it exactly compresses. This can be a guide to doing a microvascular decompression. Again, T1 and T2, Senthil have explained to you very clearly that the difference between these two. Any advances, it gives a more clear-cut imaging and also a less radiation frequencies. So that is what we use for MRIs. There is diffusion tensor imaging, which also produces valuable information about the alterations in nerve and results of neurovascular compression. That cannot be captured by any other MRI. That is another type of imaging. And there is a brain gray matter analysis also. These are all basically radiological techniques which they can identify clearly the exact pathology behind this, so that we can identify the pathology in particular and not treat in general.
Absolutely, sir. Thank you very much.
Yeah.
So with this, we're going to move to the next question. Management of local anesthesia induced nerve injury, right?
Right.
So
this is something which we see across in daily day-to-day practice, right? Sometimes you injure the nerve by using injections. If you don't use a proper technique, or if you've been a bit harsh, you may injure the nerve fibers directly. Most likely it doesn't happen, but if it happens, all you have to do is be a oral surgeon, right? Talk to the patient, right? You have to do a talk on patient. Reassurance, both reassure yourself as well as the patient, right? Because that mostly it will be temporary, because it's not going to entirely sever the nerve. It's not your needle prick injury is not going to cut the nerve or damage to an extent where it is irrecoverable. So always reassure the patient, talk to the patient, tell them that paresthesia might last for a few weeks, or the worst case for a few months, right? Just tell them eventually it will recover. The patient will be fine. They mostly these are all sensory nerves, so the function won't be a big issue, right? A little bit of odd numbness will be there, but they can manage with those things. So unless you just treat the patients and you keep observing, you call them every now and then you keep observing, and then see how does that improve. Mostly you can see some improvement. Do all the tests, like 2-point test, everything, and tell them that it is improving. Right, that itself gives confidence to the patient, and eventually they will recover. It's not alone for just camouflaging or convincing the patient. It actually recurs, actually reverses back. So don't worry about too much about needle prick injuries. So it will be. You can attempt a single steroid injections at the site or oral steroids. Sometimes the edema and other things may subside. Anti-inflammatory properties. It will make the nerve to heal well. That also can be tried. If there is completely paresthesia, then think about micro neurosurgeries. That right now, other procedures, bigger procedures. If there is completely paresthesia, which is not recoverable, even after a few months, and the patient is very apprehensive about it.
Thank you, sir. I think the most important thing is that we need to have empathy, because if we are going to brush off this patient,
don't brush off. That's what I'm saying.
Chase the patient.
Right.
We are going to be in a bigger soup.
Yeah. That's why I tell you, do all the tests. See, tell them that it is improving. You also get convinced. It will improve actually. To be frank, it does improve. Just see if you are meticulous, and then record every time where all you feel the pain, how does the pain, tingling, and the regions. You just mark regions like everywhere, and then touch to brush technique, all those things. Tell them it is improving. If you record it and you tell them the improvement, the patient will be very happy, right? Absolutely. So they will know that they have hopes.
Thank you, sir.
Don't tell them it will go on there. Yeah.
We are going to go to the next question, which is the treatment of glossopharyngeal neuralgia.
Right. Again, same treatment line is going to be the similar one, right? Basically, medical therapy and peripheral therapy. But one important question about glossopharyngeal: what do you do for trigeminal neuralgia? Right? You give a test block. How do you give a test block for a glossopharyngeal neuralgia? Right? That is one question which I commonly ask in the Viva. Right? You have a cocaine spray, right? You have a ligno spray. You can just put it on the throat and then see for the reflexes, right? That is how you test for a glossopharyngeal neuralgia. So that is one difference between trigeminal neuralgia and glossopharyngeal neuralgia. Other treatment is going to be the medical, and this management is going to be the same, except for the branch, right? Except for the nerve, which needs to be recompressed at a later stage. But medical management is going to be the calm, because it's going to be systemic. It's not specific. So all the medical managements, same line of treatment for glossopharyngeal neuralgia as well.
Got it, sir. Okay, so moving to the next question, what is a Dandy Janetta procedure?
Right. Dandy Janeta procedure is the microvascular decompression. It's a neurosurgical procedure, and Dandy is one neurosurgeon and Janeta is another neurosurgeon. Both are not the same, right? Dandy was the first one who started this microvascular decompression because this is a posterior temporal approach, right? It's a post-occipital approach. Dandy is a neurosurgeon. He identified basically, he was the one who just thought that there is some compression happening in the trigeminal roots, right? He was the one who decided mostly tumors and some of the lesions around the brain, which compresses in the posterior cerebellar region, which compresses the nerve, right? That is the reason. So once you remove the tumor or once you remove the compression, it clears off. That was the one which was Dandy has been doing. And Janeta, actually, he is a junior most surgeon, right, among his department. The thing is, these drastic procedures were not even encouraged for doing for a trigeminal neuralgias, because that's a huge procedure for a not so, I will tell you, right, it's not a very serious illness, right? You can still manage, though it is annoying, you can still manage with peripheral procedures. So it is not being advocated in those days. But Janeta being a, once, like that is a story which goes there. Once there was the seniors was not there, so he started operating. Then he instantly found out that a superior cerebral artery is the one pulsatile, which is hitting on the nerves. Then he decided to separate those nerves and then keep a barrier in between the nerves, which is hitting the nerves that causes the tick. So that paved the way for your recent technology, which has been very useful. Janeta's procedure, which is commonly compressed microvascular decompression, right? That has been used nowadays. That is superior cerebral artery, the root, and then all you have to do is separate these things, keep a sponge in between, Teflon pad, some sponge in between. That is all you need. But you have to open up the skull and then go to the brain.
Thank you very much, sir.
And
thank you for the wonderful historical perspective.
Yeah, one more anecdote of this is, which again is my most commonest Viva question is, who's the film actor who got this procedure done? Right, Paul, you should be knowing. He's from your area.
Yes, sir. So right, we'll keep that for the Viva only.
Viva. It's Salman Khan, right? So that's
yes. And okay, so management of implant-related nerve injuries.
Right. As far as implant placement, try to avoid nerve. That's the basic rule, right? So you have all the X-rays and CBCT, all those things, and implant is a expensive procedure. So do spend some money on investigations as well to avoid the nerves at all costs. Right. If at all it happens, this is the algorithm. If the patient who has just recently placed an implant has some issues with the nerve, straight away check with another X-ray or a CT scan, see what is actually exactly happening, right? If the implant is encroaching the nerve, mostly it's the inferior mandibular, inferior orbital, inferior alveolar nerve. Mostly that is the cause. Just see whether the implant is impinging on the nerve or it is causing compression. If it is so, that is a straightforward procedure. Just remove the implants and then reposition it, right? Use a smaller size implants, just and then again test for neurosurgical simulations and nerve study. You do the nerve studies and see how it goes. If there is improvement, fine, that's the end of the treatment. No further treatment, it will recover on its own. If the implant or the drilling procedures have injured the nerve, then it is not going to improve. You just again do the same protocol like your local anesthetic injections, like that. Check periodically, evaluate again meticulously, see if it is improving. And if it is not improving, then you have to, there is no other choice except for going for a micro neurosurgery, where you have to repair the nerve, right? That is how it has to be done. But micro neurosurgery is not all that successive, right? You have to clearly explain the patient the rate of success for the patient also, because it's a huge procedure. You have to explain. Unless the patient is really desperate to get it done, don't do it, right? And if there is no implant encroachment on the nerve, if you see that nerve is totally away from your implant, then probably your drill bit must have injured your nerve. Then again, same protocols, observe. If it is improving, fine, there is no further treatment. If it is not improving, same thing. Wait for 3 months And if there is hypoesthesia, if there is exaggerated pain, then go for microneurosurgery. Sometimes you end up in the painful stimulus, right? That you need to intervene. Right? If there is paresthesia, at least patient can manage. If there is a painful stimuli, then you have to intervene and then consider microneurosurgery.
Thank you very much, sir. I think the most important thing today is that we can use guided surgery to avoid this complication. Not completely, but at least to a great extent.
Yeah, even a simple stopper will avoid this. Even a simple stopper while using a drill bit is going to avoid it, right? Meticulous planning is, it's not even meticulous, it's a simple planning actually. It's not a rocket science, just nerve is there. All you have to use to choose the right size. And drill bit, you have to have the control, right? You have to have a stopper, that's it.
Absolutely, sir, absolutely.
Because
okay, so moving on to the...
Correcting a nerve injury is difficult. Microneurosurgery, it can be theoretically spoken of, but it is not an easy procedure. It's not a hugely successful procedure as well. It takes its own time. It has its own drawbacks as well.
Absolutely.
Yeah.
Absolutely. And moving to the final question for today, static and dynamic procedures for facial paralysis.
Yes. Facial palsy is one of the most commonly asked questions, right? Bell's palsy. Mostly it happens, sometimes it recovers on its own, right? Idiopathic facial palsy, it recovers on its own. Suppose it is not recovering, and then it's a huge procedure. It needs correction because it's be annoying for the patient. They won't be able to close the mouth. There'll be a facial disfigurement, all these things. They definitely need treatment. There are a few options of treatment. One is camouflaging procedures, and other one is static procedures, right? You can close the eyes because it's kept open always. You can do a partial closure of the eyes, which will benefit like corneal dryness and other things may happen with the eyes. So all these things you can do. That is called static procedures. You can, for a brow paralysis, you can do a brow lift, right? Direct or a endoscopic or a threaded one. A lot of plastic procedures are there for a brow lift, brow paralysis. And eyelid paralysis is the most embarrassing point. So you can add weights in the upper eyelid. Gold or platinum is usually used. You can implant with the gold weight or something like that so that the eyelid closes. Or you can do a tarsorrhaphy, lateral tarsorrhaphy, so that there'll be a partial closure of the eyes because it'll be wide open. So there'll be a partial closure of the eyelids. And lower eyelid positioning or lateral canthopexy. You can cut short your eyelid a little bit so that or you can strip off a bit of tarsal plate and then tighten it, right? So that your eye will be a bit closed. These are all static procedures where they won't be able to completely move the eyes and other things, but it will be a static procedures which will camouflage to an extent. And nasal valve collapse also, you can use a nasal alar suspension with a fascia or with a braided suture. There will be something called as a sutures, right? It will have some hooks in that. So that can be used even for brow and this nasal valve collapse. And other oral commissures, you can use a sling. You can use the fasciolata. You can tie it along with the circumzygomatic suspension. You can use a fasciolata or even prolene is used, 1/0 thick prolene along with this orbicularis. This corner of the mouth can be sling and it can be suspended with the zygomatic arch so that it will be permanently a little bit moving away. So it won't have the compression, but these are all static procedures. They are not animated, right? They cannot, they'll be fixed always, right? That's how we have to do a static procedures for facial paralysis.
Okay, so moving on to the next slide.
You wait. Yeah.
So no, please continue, sir.
Yeah. Always you have to wait for a year, right? For a facial paralysis, you just find out what is the reason for idiopathic facial paralysis. Mostly it will subside on its own, right? All you have to do is observation. Don't jump into procedure straight away. So you always have to wait. When there is no hopes for recovery, then you do all these procedures.
Got it, sir. Got it.
And physiotherapy also helps. Do a lot of physiotherapy and adjuvant therapies also for all these things. Strapping, everything can be done, tried at the lowest. Have the surgery at the end. Right. Dynamic rehabilitation. You can use either muscle transfer or nerve transfers, right? That is mostly long-standing facial paralysis will have an atrophy of the muscles. So that is one thing you have to keep in mind. If the nerve supply is lost to a muscle, that goes for disuse atrophy, right? So these things you have to keep in mind. If there is an algorithm again, if the facial paralysis is irreversible, if it is yes, right, facial muscles, the motor plates and the muscles are all intact, right, then you go for procedures of nerve grafting, right, cross nerve grafting. You co-opt with the opposite side facial nerve, right? You harvest a graft and then co-opt with the other side of the face. That is one procedure which is done for animated procedures. So that, but the training has to be well, right? Your muscles has to be trained. Like patient will themselves get trained when they contract, when they want to do things, they have to keep trained, right? That is how you do a facial nerve grafting. It's a cross. You take a graft and then innovate, go across the over the lips or over the glabella for the eyes. So you do a cross nerve grafting, right? That is cross nerve grafting. And regional nerve transposition or a babysitter. Regional nerve is your localized nerve, nerve to masseter, another thing that can be also be done, but it doesn't work like a cross nerve grafting. Cross facial nerve grafting is the best possible option available. And something called as a babysitter procedure. What is a babysitter procedure? You buy time. This is a double procedure, right? Where you first you use the local nerve, hyperglossal our nerve masseter, and then co-opt with the local facial nerve, right? That will save your nerve. I mean, save your muscles from going atrophied. So it'll have some time being. It won't be as effective as a cross nerve grafting, but definitely sometimes this may alone may be the treatment, right? If it works well, that is fine. Otherwise, this will at least serve the purpose of saving the muscles from being atrophied. Then after a few months, you can do the cross nerve. That is why it's called as a babysitter procedure, because you take care of the muscle for a few months, then hand over to the cross facial nerve innovations, right? That is called as a baby procedure. And if there is a facial muscle which is atrophied or traumatized, which is not recoverable, then you need a muscle as well. The nerve grafting alone is not going to be enough, because when there is no muscle, what is the purpose of nerve? So you have to transfer the muscle also. Either you can use a regional muscle transfer. The most commonly used is your temporalis, right? Temporalis muscle, which is quite common here. You just rotate and then keep it here. I'll show you a picture on the next slide. Or a microvascular free flap, right? Gracilis muscle mostly, which is used. Give the muscle bulk, then do the co-optation as well with the nerve, right? You have to do a cross innovation of the facial nerve as well with a nerve graft and other things. I'll just show you a procedure of nerve graft and the reanimation procedure with the temporalis and the facial eta, so that you can have a better understanding of how it works. These procedures are dynamic procedures. The patient will be near normal, right? They can move the muscles which has been transferred, unlike your static procedure. That is a camouflaging procedure. This is a really animated procedure where they can move your lips in proper training over a due course of time. Yeah.
Okay, sir. So just the case. So there's a wonderful case that is being done by sir. So sir, can you just take us to the procedure?
Yeah. This is the sural nerve, which is the commonest one and easier to take. Actually, incision will be a bit more. It's very simple incision. You need not cut all the way. Just make some incisions here, here, and here, and here, right? Just a snaps, and then you can feel the nerve. Actually, it will be like a tightrope, right? Once you elevate at one point, you can just feel it and then make incisions here and there, and then cut at one end and then pull it out easily. See, such a long nerve you can easily get. This is a sural nerve grafting procedure. Can we move on to the next slide? Yeah, this is your temporalis, right? Basically, use a bicoronal hemicoronal incision. Go as high as possible, almost to the midline, right? Cut the entire along with the fascia, right? Cut the entire muscle and then split it. And then you can divide the fascia and the muscle as well at the top end. Don't divide the fascia and the muscle. Have a bit of attachment so that will give some extension. Just rotate your temporalis like this. And then at the end, you can have the fascia which is split. There's a fascia of the temporal fascia. So don't detach this region. And then you can get a still elongation. Still, this might not be enough. You may have to use a facial eta, which is taken from the thigh. Do you have that slide, Paul? The facial eta? No, okay. Anyway, facial eta can be go to the previous slide. Previous one, yeah. Previous one, yeah. And you can still extend, try a fasciolata along this, and then you may have to 3 or 5 even branches, right? One goes to the upper lip, one goes to the lower lip, one goes to the upper lip, and one goes to the lower lip, right? All these things. Or you can put it one for the upper and lower eyelid, one for the angle of the mouth, which can be suspended here, right? That is how. See, another all subcutaneous plane. Make a nick here, make a nick here. See, this is tunneled here, pulled out here, and then sutured here. Tunneled, pulled out, and almost on the medial side. It has to be sutured here on the medial aspect, right? So that you get a proper eye closure. And again, angle of the mandible, you just make a nick here, one for the upper lip, one for the lower lip. Tunnel it, everything underneath. Almost go to the midline. Don't leave it here. You have to go to the midline and then suture. So that all your fibers, once the temporalis contract, so all these things can be animated. This is the most commonest procedure which we use for facial reanimation as for a dynamic transfer procedure, which can be local procedure. And this is very much our procedure. You need not go for another surgeon, particularly for microvascular and other things. You might need a vascular surgeon or a plastic surgeon, right? These are all our procedures which we can do it on our own. Of course, microvascular, we are some of trained, but this anybody can do it, right? So this is also a procedure. We can get it done.
So just out of curiosity for the students,
yeah,
when you do a procedure like this, what is the exact mechanism the patient uses to be able to smile or close the eye? What do we train the patient to do?
What does temporalis do?
Exactly. So basically, that's the point. That's the point,
right? So you have to close your mouth, right? That's
exactly. You have to bite, you have to close your mouth, and that is what is going to make these muscles work. And basically the patient has to train themselves in front of a mirror to get it right.
They need to be taught a lot, right? They will get trained what to action makes it, because they will be some time which they get used to this.
Exactly.
Right? They have to go for physiotherapy as well. They will get used to it.
They will get used to it. So we need to, both things are equally important.
Yeah, fine.
Okay,
another favorite Viva question: who's the celebrity who has a facial palsy? Right, some celebrities, very famous personalities, Bollywood, Hollywood actor.
Right.
Right. Sylvester Stallone. He lives with facial palsy still, but that has become a style. Okay, a crooked mouth. So it's not always a disease. You can come over without doing a surgery as well.
Absolutely. Right. Okay, so we have come to the end of this presentation. Thank you very much, sir. We've managed to cover a lot of ground, and especially on a topic like neuralgias. So thank you very much for making it lively and with all the historical perspective that we don't normally get. So with that, we'll wrap up the session. I'm just stopping the screen share.
Yeah, thank you, Paul. Thank you for
thank you very much, sir.
Moderation and help.